Good morning, everyone. Thanks for coming out on a day like every day in April and May, a very wet day. I'm Joe Antos of the American Enterprise Institute, and we're here today to talk about the 2016 Medicare Trustees Report. I want to thank my friends at the Brookings Institution. Many of you may know that AEI holds this type of event every year. We've been doing it every year for at least the last 15 years. It's longer than that, but AEI's records seem to have expired with the turn of the century or something like that. But we had a scheduling conflict, and fortunately, I was able to reach out to, as I say, my friends at Brookings, Paul Ginsberg, who can't be here today, and DJ Norquist, who paved the way for us holding this event at kind of the usual time, at a place not too distant from where the AEI audience often shows up. Anyway, I'm very, very grateful. Many of you may know that AEI is moving. We were supposed to have moved months ago, but let's not discuss that. And I want to thank my friends at Brookings for putting up with the construction debris, the total disruption of pedestrian traffic, and everything else that has gone on just a little ways down the road. Ideally, I'm not making any promises, but ideally we will be better neighbors in the future. We'll see about that. Anyway, I want to introduce Paul Spitalnic. Paul is the Chief Actuary for the Centers for Medicare and Medicaid Services. He's not just the Chief Actuary for Medicare, he's the Chief Actuary. One thing that I think is maybe not as appreciated as much as it should be, but a lot of people often say that they're a little frustrated about policy in Washington and especially healthcare policy and certainly Medicare policy. The concern is that it's really policy decisions are driven more by politics than they are by analysis. Well, I don't know if I want to say thanks to the ACA, but due to the ACA, Paul Spitalnic may in fact be the most powerful health policy person in Washington, certainly with regard to Medicare, because there is the IPAB, which we will talk about today, and the actuaries' projections determine whether the IPAB will take action or not, at least according to the way the law is written. There's also the Centers for Medicare and Medicaid Innovation, and once again, the actuary's office issues a judgment, is required to issue a judgment whether some new approach to payment or delivering services or something related to the Medicare program saves money or improves quality or does one or the other. And if so, then the ACA has given the Secretary the authority to expand that project beyond where it started as a demonstration project. So in fact, the actuary's office is pivotal to potentially very substantial changes that, at least according to the ACA, would happen automatically without the intervention of Congress. Well, we'll have to see about that. But anyway, at least with regard to those two very important activities, policy analysis will, to some extent, hold sway over politics, or at least that's the way it's supposed to be. And with that, Paul, please do your presentation, and after the presentation, we'll bring the panel up and we will argue with each other, but correcting everybody's mistakes, I'm sure. Okay. Here. Let's see. Whoop.
Does that appear? All right, great, thank you. Good morning. Thank you, Joe, for that introduction. As someone that does not develop, create, or implement policy, I would dispute your characterization of my authority there. But I appreciate everybody taking the time this morning. Thank you for the opportunity to listen to my walkthrough of the 2016 Medicare Trustees report. The title of the presentation is that Joe circulated is "Are we 1 year closer to IPAB?" And I don't think you're supposed to answer the question of the purpose of the meeting in the first 30 seconds of the discussion, but the answer is yes. We are 1 year closer. We are also 1 year closer to the Cubs winning the World Series, and me being done paying for college for all of my children. I'm not going to tell you exactly when all those things will occur, but I'll give you a hint. I'm still paying for daycare. So just to walk through my talk this morning, I'm going to just talk a little bit about the current snapshot of the program and how it's evolved over the years. Walk through the formal evaluation of the Medicare trust funds. I will answer the question about 1 year being 1 year closer to the IPAB cuts and talk a little bit about that. And also we'll talk about an issue that is discussed in the report regarding the 2017 Part B premium. Before I talk about the projections in the trustees report, those projections are 75-year projections. There's also infinite projections. So these are projections that are looking at how the Medicare program will be changing over a very long period of time. And I'd like to start with this chart just to demonstrate that the program has changed very significantly, even under a much shorter period of time. In the past 40 years, the program has moved from that left pie chart where we were talking almost predominantly about an inpatient benefit program to one that looks like the one on the right, where there are multiple different categories, multiple different services. And the point of this is really to not highlight how complicated and diverse the Medicare program is, but to talk about the limitations of doing these long-range forecasts. It is impossible to know what this program is going to look like in 75 years, just as it was impossible to know 40 years ago that the program would look like it does today. However, the reports do have very important, useful information to talk about the financial status. In order to understand the financial status, you need to do these long-range forecasts. We're talking about benefit streams and income streams over many years. And in order to understand the adequacy, you really do need to evaluate the programs over these long periods of time. This also highlights how the programs change over time. This is just looking at the proportion of Medicare spending in private plans. This is just going back, 25 years, and to see that the proportion of Medicare A and B spending that's in private plans has gone from 5% to nearly a third of the program. So again, just highlighting that programs change, and we certainly do our best to model it. So just taking a step back and looking at the current status of the program today. Program's comprised of two major parts, or two trust funds: the hospital insurance, HI, which includes Part A, mostly inpatient hospital care, skilled nursing, home health, and hospice, so institutional settings. And there's also the SMI Trust Fund. This includes both Parts B and Part D. There are two separate accounts. Those accounts need to be evaluated separately, since there's no provisions in law to allow either the benefits to be paid for by the other trust fund or for income to be coming in differently. You can see that there's generally, roughly 55 million people with HI coverage, almost 51 million with Part B, and almost 42 million with coverage in 2015. The financing of these programs are very different, and so that also leads to the need to evaluate the trust funds differently. HI, the hospital trust fund, is financed primarily through payroll taxes. 1.45% payable both by employees and employers, or the 2.9% for those that are self-employed. In addition, there is higher income, there is also a tax on Social Security benefits. On the Part B side and on the Part D side, those finances are set on an annual basis. In Part B, it's set to be approximately 25% of the total cost of providing those benefits. And in addition, those with higher incomes are required to pay an additional amount. On the Part D side, it's about 25.5% of the standard benefit is paid for by beneficiary premiums. And general revenues are the additional, are the primary source for both Parts B and D funding. And also on Part D, there is also the income-related premium for those high-income earners. So this really looks to summarize what the differences are, the baseline for what we are building the projections off of. And you can see that the differences between the 2016 report and the 2015 report for what we were estimating for spending to be in 2015 are not very different. And in fact, some of the differences summarized here are actually not even true underlying benefit differences. There's a little more to the story there as well. But you can see on the income side, there was, the actual income was a little bit less than expected. And expenditures were a little bit more than expected on the HI side. On the Part B side, very close, less than 1% differences on both the income and expenditures. And on D was also a little bit lower, but that really masks what's really happening with the drug benefit. Talking a little bit about the specific differences on the expenditure side, one of the larger differences was actually a reconciliation payment. Effectively, the Part A trust fund paid out, had to pay out an additional amount of administrative expenses. There was just a misallocation between A and B, so actually roughly $800 million of the $3.2 billion difference on the HI expenditures and the 1.7 deficit on the or lower than estimated expenditures was actually just a misallocation. So the differences in benefit spending was actually even less. Not trying to say we did a great job making these projections, but we did a surprisingly good job making these projections. And as you can see by these lack of significant differences, most of the projections within the report are fairly comparable to those included in the 2015 report. This also just looks out throughout the entire 75-year projection period and summarizes where the income is coming from into the program. If you look at basically the bottom two, the payroll taxes and the tax on OASDI benefits, and the top line, the deficit, those are basically the HI Part A funding. And if you look at the middle ones, the premiums, the state transfers, and the general revenue transfers, that's really the Part B and Part D funding. On the HI side, you can see that the deficit is basically the portion of current revenue sources that will be that will not adequately finance all of the future benefits that are currently expected to be paid out of or currently committed to from the program. We'll talk a little bit about the depletion date. That's usually what the headline is from the report, and we'll talk a little bit about that in a moment. But here you can see that the bluish section there in the middle, the general revenue transfers, that is a large and growing share, and that really just represents a growing contribution of what's happening in the Part B and Part D benefits of the program. So in order to formally evaluate the status of the trust funds, which is the purpose of these reports, you need to evaluate HI separately from SMI. The evaluation on HI is basically, are the assets plus projected future income adequate to finance future anticipated benefits? And given that both Part B and Part D funding is set annually on for those programs, there are no long-term solvency issues, but it doesn't mean that there are no underlying concerns. As those benefits continue to grow, they represent a growing share of both GDP and of federal resources and beneficiary resources. In addition, in the report, the trustees ask the Office of the Actuary to estimate an illustrative alternative scenario. It's neither an endorsement nor an indicative of what is, I've read it characterized as what we think is really going to happen. That's not the purpose. The purpose is truly just to illustrate what the potential understatement would be to the extent that current provisions of current law are not implemented fully in the future. So if the two major provisions are related to, one is a feature of the ACA and another is a feature of the MACRA. For most non-physician providers, in all future updates, their payment rates will be reduced by economy-wide productivity. Throughout history, economy-wide productivity has been greater than the level of productivity that could be achieved in the health sector. And so as that differential accumulates, it effectively would serve as, or could serve, if that differential continues indefinitely in the future, that would serve as effectively a reduction of payments to these non-physician providers, including inpatient hospital and most others. On the physician side, the recently passed legislation that repealed the sustainable growth rate formula, the SGR formula, specifies the physician payment rate updates for all future years. And depending on whether a provider will ultimately be in an APM, an alternative payment mechanism, or in the MIPS, the merit-based incentive payment system, they will be either getting a 0.75% or a 0.25% payment rate update in each and every year into the future. And that's the payment rate update, whether inflation is 1.5% or whether it's 3 or 4%. Given that we are assuming, the assumption in the trustees report is that basically the underlying cost index, Medicare, the MEI, Medical Expenditure Index, is expected to increase at 2.2% for physicians. This payment rate will also create a gap between what, how their payment rates will be increasing relative to what their costs will be increasing. And so there's an illustrative alternative that presents what costs would be if these two provisions are not necessarily eliminated, but phased out over an extended period of time. In addition to that, and I know we'll talk about this a little bit later, you also need to eliminate this alternative eliminates the IPEP provisions as well. So just looking at short range, the short range actually tells a not terribly concerning picture with respect to the HI Trust Fund. You could see that over the recent past, over the last 20 years or so, income and expenditures have generally been moving in the same direction. You can see income dropped off after the recent Great Recession and is actually expected to grow at a faster rate than expenditures for the next several years. Starting in 2020 and thereafter, expenditures are expected to exceed income. So in the short range, things don't look so bad on this chart. This chart otherwise shows what the account balance is within the trust fund. And basically the trust fund in this year's report is expected to be depleted in 2028. That is 2 years sooner than estimated last year. And on here you could also see the prior year trajectory. And generally speaking, when you have relatively low balances, it doesn't take significant moves to make to have a change in the timing of when the trust fund will be depleted. And as we'll walk through, the relative changes in the projections are fairly minor, but we do have this 2-year earlier depletion date. So looking at the bigger picture is really the way to characterize the actuarial balance of the trust fund. And it really looks at a present value of the future income and the present value of the future costs, and relates it to taxable payroll. That's the taxable payroll is the basis for the current payroll taxes into the system, and so that's a good measure for how the cost and income are moving forward in these projections. You can see that there are some differences here between the 2016 and 2015 reports on both the income and the cost side. The net bottom line difference is that this year the actuarial balance is the deficit is slightly larger than it was estimated to be last year by 0.05% of taxable payroll. It's a relatively modest change in any terms, but we also had a methodological change this year. In prior reports, there's a small group of what's called uninsured beneficiaries, and I did not give the title of uninsured beneficiaries to these people that are covered in the Medicare program. But basically, there's a group of people that do not have 40 quarters of coverage that get bought into, that can buy into the HI program. There's a premium rate set for them each year. It's roughly about 600,000 people. And the assumption in prior reports, we've always had a difficult time just getting data on both the cost and on the revenue side for these guys. But we've been able to break this out this year, and we have built it into the projections. And so there's a methodological difference in that we've added both the income and the cost rate for these uninsured beneficiaries. And as you can see, that our prior assumption was that these people were not affecting the actuarial balance all that much, because the expectation was that they're fully paying the full cost of the premiums, and they've got benefits going out. We were never able to align that these are truly average beneficiaries and that their costs truly match up with the average. Turns out that they're very slightly more costly, but as you can see, these numbers are fairly small, so these do not move things all that dramatically. And so you can see that even accounting for these differences, the income rate is hardly changed, and the cost rate is slightly changed. And the biggest reason on the cost rate is that there was a slight bump certainly in the short range inpatient utilization assumptions. And basically, the assumptions are that for 16 and 17, the rate of decline of inpatient admissions it was slower than what we expected to be. So the inpatient admissions are still slowing, but not as fast as what was projected last year. This actually gets into the finer details, and you're not wrong if you say that minus 0.01 is a relatively small difference, and that is the largest difference for any one element of these factors contributing to the change in the actuarial balance. The change from minus 0.68% of taxable payroll in the 2015 report to the minus 0.73% of taxable payroll in the 2016 report. Valuation period, so we're 75 years has just shifted 1 year further down. We basically replaced a relatively lower deficit year with a higher deficit year by basically shifting the period forward. The base estimate, it just includes the incorporation of additional data, the hospital assumptions, as I mentioned, on the inpatient side. Some other, there's a whole host of details in terms of a whole host of assumption changes from year to year in these reports. I'm not sure anyone other than Keith Fontenot was up till 2 o'clock last night reading all of them and getting excited about them and talking about them with me this morning. But there's a whole host of changes to the underlying economic and demographic assumptions, and methodological, that was that uninsured difference. So all told, there is not much difference in this year's report from last year's report with respect to the actuarial status of the HI program. This is another way to look at the program in terms of looking at the income rates and cost rates. You could see that these lines are on the cost side. The cost sides increase. At one point, and you see in 2028, the cost and the income rates come down. And really what we're showing there is that once the trust fund is depleted, only benefits that are currently being, the only use of revenues will be those that are coming into the program will be able to be used to provide for benefits at that time. You can see that on the left side of the chart, in 2028, when the fund is depleted, income will represent 87% of what the expected costs will be in that year. So even when the fund is depleted, it's not that there is no more income and no more benefits and the program shuts down. It's just that the amount of income will be inadequate to fully fund all of the expected benefits. And this really looks at the differences in the two reports. And as I mentioned earlier, there's not a lot of difference in those two lines. However, if you layer on top of those two lines what the cost would be under the illustrative alternative assumption, you could see that there is a pretty significant divergence between the cost estimates projected under the current law approach that's included in the trustees report and the referenced illustrative alternative assumption. And so those productivity offsets, in particular on the HI side, really lead to a very significant difference in terms of what the cost would be under this program. You can see that those differences start off very small, but it's amazing about compounding that when you start off with small differences over a very long period of time, they mature into very large differences. And that's really the point of the illustrative alternative, is just to demonstrate that should those cost savings aspects of the programs prove to be not implemented, that costs under this, as illustrated by this alternative projection, could be significantly higher than represented in this report. On the Part B side, this is also the fact that the financing is set annually. There's never a lot of interest in terms of looking at the income and outgoes on a comparable basis because the program is always in financial balance. As you can see, though, as the program continues to mature and we have more baby boomers coming through the program, we are expecting that costs will continue to increase. Similar story on the Part D. And you can see that we are slightly higher than where we were estimating last year on the Part D side. Again, this is, those differences are not very large, but those differences are generally attributable to an even stronger increase in specialty drug use in the Part D program than we were estimating last year. This kind of just pulls the two programs together, sees how the premium contribution and basically the federal expenditure contribution of this program will change over the next 75 years, and we get from this is as a share of GDP. So the programs eventually get up to just under 4% of GDP. Again, looking at the bigger picture of the changes from the 2015 to 2016 report, Part B expenditures as a share of GDP was basically right in line with what we were expecting for the 2015. For the longer range, 2085, again, not much of a difference there as well. Similar story on Part D, moving in a little different directions, but again, not a lot of difference in those underlying projections. This looks at the long range as a share of GDP just for Part B, and you can see some of these, the payment rate update in particular actually is what's causing those declines in the later years. The fact that this peaks out at the 2.5% and then drifts downward thereafter is largely due to the fact that the payment rate updates are just not expected to keep up with, in this case, the underlying GDP growth. So again, it's important to compare this to, this actually compares total Medicare expenditures as a share of GDP. We're currently at 3.6% of GDP. Under the current law, projections expected to grow to 6% of GDP, but under the illustrative alternative, is expected to grow up to the 9.1%. So obviously a significant difference there. So now we get to Joe's favorite part of the talk, the IPAB. And so each year the chief actuary needs to make a determination as to whether or not the Medicare calculated amounts exceed a certain target amounts. And for the 2016 determination, the Medicare growth rates are 2.21% as compared to the target rates of 2.33%. Therefore, there is no determination in the 2016 trustees, based on the 2016 trustees report. And I issued that determination yesterday after the report was finalized. Talk a little bit about how this calculation works. Basically, the Medicare is the Medicare portion of the IPAB determination looks at a 5-year average of Medicare per capita costs, looks at the current year, 2 years prior, 2 years forward, and that's the basis for that calculation. The target rate is set as a function of either CPI and medical CPI for the first, was it through 2017, and then transfers over to a GDP plus 1 type calculation. But if you look down one row at the 2017 row, you could see that the Medicare calculated amount of 2.82 exceeds the target of 2.62. So based on the current Medicare trustees report projections, it would be expected that the IPAB there would be a determination for the IPAB in 2017. What does that mean? That means that I would have to issue that the Medicare targets exceed the Medicare expected growth rates exceed the targets, and that savings will need to be generated to effectively account for this 0.2% difference. So if these projections exactly hold next year and at this point next year, that's the determination. Then I'll say that there is effectively however many millions of dollars would need to be saved through various proposals. So that will be done in 2017. The next step would be in 2018, a proposal would actually need to be delivered to Congress. It should be delivered by the IPAB. If there is no IPAB in place, then it'll be delivered by the Secretary. Congress then has the year to consider it. If they pass something that equally generates that level of savings, then that's done. Otherwise, that savings proposal would be implemented in 2019. So the sequence works for example, for next year, 2017 would be a determination year, 2018 would be a proposal year, 2019 would be the implementation year. I do not have the answer as to when the Cubs will win the World Series. The other key issue that's really highlighted in this year's report is around the Part B premium. And I'm going to walk through where we were last year when we were having this conversation. And that was that there was, in last year's report, there was an expectation that there would not be a cost of living adjustment for Social Security benefits in 2016. There is also a hold harmless provision in Social Security that does not allow net Social Security checks to go down. And that includes the effect of Medicare Part B premiums that are withheld from Social Security checks. So roughly 70% of beneficiaries, despite the fact that the Medicare Part B premium went up from $104.90 in 2015 to $121.80 in 2016, roughly 70% of beneficiaries that have their Social Security, that have their Part B premiums withheld from Social Security, they're continuing to pay $104.90 in their Part B premiums this year. Now, if not for provisions of the Bipartisan Budget Act of 2015, the remaining 30% would have had to shoulder the entire increase of all of the necessary premium increase to generate the adequate funding for the program. But the Bipartisan Budget Act was passed and basically said we'll allow for a transfer from general revenue into the Part B trust fund. The amount of that transfer will effectively be the amount of the foregone revenue for the fact that the hold harmless provisions are preventing beneficiaries to contributing to the program to the full extent of what they otherwise would have been calculated. That will count as a transfer into the Part B program. We're also going to add $3 per month to the otherwise calculated Part B premium until that transfer amount is fully paid back. There's also a provision that says if there's no cost of living for 2017, these provisions will again apply. So if there's a 0% COLA for 2017, then there'll be another transfer, there'll be another $3, and we'll basically be able to kind of continue on. So the expectation, as I mentioned, BBA provisions will also apply if there's no COLA in 2017. On the other side, if there's a sufficiently large COLA, cost of living adjustment for Social Security benefits in 2017, the hold harmless provisions will not have a bite to the premium calculation. If the 70% are experiencing, the $10 or $15 increase in their Part B premiums, then there would not be this foregone revenue that you would need to otherwise collect from the smaller 30% of beneficiaries not held harmless. Similar implication, the Part B deductible, I failed to mention this, but it is also calculated based on the same function of the premium. So to the extent that there's a large increase in the premium, there's also a large increase in the deductible. So the trustees' assumptions are that there will be a 0.2% cost of living adjustment for Social Security. At a 0.2%, beneficiary Social Security checks will go up by a small amount. 0.2 is not very large. On average, we're thinking it's about $3 a month. Those beneficiaries would then contribute that additional $3 per month to the Medicare Part B premium, but that's not sufficient to make up that roughly $15 gap between the current premium and what they're currently paying, the $104.90. So we still have that leveraging effect of where we need to get the additional funding from the relatively small number of the 30% that it would otherwise be paying. As a result, we expect, the projection is that those 30% would be paying $149 for the 2017 Part B premium. It's similar to the concern that we had last year when the expectation was that the hold harmless provisions would also apply. It's a little bit different this year. There is less certainty as to whether this is going to occur. So there's still a chance that we'll be below 0. There's still a chance we'll be above 1. So there's less certainty on the COLA. The differences that we have to make up aren't as large as what we had to make up last year. And there's just going to be more information available as time goes on. Saw that the CPI came out a few days ago, and looking at that, we're at plus 0.09. So that pretty much is the worst possible situation. Plus 0.1, 1/10 of 1% COLA would be the worst possible situation for the amount that would need to be made up for in beneficiary premiums. So obviously, this will play itself out. Last year, facing a similar circumstance, not exactly the same circumstance, there was legislation that addressed it. We'll have to see how this is going to play out as more information becomes available. I think that is my presentation. So at this point, I'm going to turn it over to Joe to, I think, ask me some questions, but I'm going to come forward. Thank you.
Thank you.